Everybody, I am Gustavo Tolosa here, the webinar coordinator for Dr. McDougall in this wonderful morning, at least here in the United States. And I think that we have a lot of guests from all over the world and the country. And today we have a great topic for discussion, cancer. And it's not only today, but next weekend on Saturday as well. Many of you already know Dr. McDougall. He does not need much of an introduction, but of course he's a real doctor, physician that takes care of patients. Actually, this weekend there is a 10-day program, and I want to welcome. Thank you, Dr. McDougall, for being here today. I know this is a very busy weekend for you.
It has been busy. We put on the best advanced study weekend we've ever put on last weekend, and it was nice that you were there in Santa Rosa. We do these twice a year. And we've got a phenomenal one coming up. And then starting today, I get a chance to personally take care of patients, which I enjoy doing very much. And we have about 40 people coming to our clinic today with all kinds of problems: heart disease, diabetes, some healthy people, probably some people with cancer. There are all kinds of different ailments that we'll be taking care of with our staff here in Santa Rosa, California. But the topic today is a topic of cancer. Last couple of webinars, we talked about obesity, which is, of course, common, not too scary. But cancer is scary. And cancer is a diverse problem. In general, you think about cancer as a situation where some type of cells in your body just go haywire. They grow like wildfire, and they replace your other tissues. And as a result, you die from the replacement of normal tissue by cancer tissue. I think, to be fair and to get down to a simple, understandable discussion, I would like to just talk about solid cancers, solid tumors. Those would be tumors in the breast, in the brain, the colon, the lung, the uterus. These are, solid masses. They're, like they get like that, and then they make solid masses in other parts of the body called metastases. And I want to talk to you about these in relation to prevention, to early detection, and to treatment. And I believe once you understand the mechanisms involved in these three areas, you'll have a much better understanding of cancer and why cancer is such a difficult disease. The way cancer kills in general is it starts as a single cell, say in a breast or a prostate or a colon. And then it divides into several cells, say 1,000 or 1,000,000. And somewhere along that division route, what happens is some of these cells, they get out of the original tumor, usually through the venous system, the veins, and they spread to other parts of the body, say to the brain, the lungs, the bones. And in those new tissues, some of these cells lodge, and they have the ability to grow also. And so they double, triple, and they become 1,000 cells, and they become masses big enough in the lungs so that you don't have any lung tissue left, or they become masses big enough in the brain so you don't have enough brain tissue left, and you die. It takes a certain number of doublings for this to occur. Well, I've been writing about this and studying about this, and we're going to talk about early detection and treatment today. Next week we'll talk about the dietary implications of cancer, but I want to give you some idea what you're looking at in terms of how to deal with cancer in terms of prevention. You think prevention is early detection. I mean, that's what we've all been taught is the way to prevent dying from cancer is to go and get a colonoscopic examination, where they put a tube up your butt, or to check your breast with your fingers, or x-rays, mammograms, breast self-examination, or to do a blood test such as a PSA test, or have a doctor do a finger test in your rectum to check your prostate. You think that's prevention. That's not prevention. Well, that's detection, and early is a misnomer, and we'll talk about that in a little bit. That's detection of cancer. So when somebody's out looking for cancer, they're going to find more cancer. So there's nothing about preventing cancer here in looking for cancer. Looking for cancer, you find more cancer. You find more people that are now cancer victims, diagnosed with cancer. So do understand that any early detection screening tests are going to add to the cancer business. And these screening tests add in a big way. When you go looking for cancer, you find thousands and thousands and tens of thousands of people with cancer. Now, some of these people would have never known they had cancer if you wouldn't have been busy looking for it. It would have never developed in their lifetime. It would have stayed unseen. They'd have died of a heart attack or an auto accident or old age before the cancer is found. So in that case, you found cancer in a person that wouldn't make a difference in their life. It would just be incidental, so to speak. You would have overdiagnosed the patient by finding a disease that would have never troubled the person. What you're trying to do with early detection screening, like PSAs and mammograms and breast self-examination and colonoscopy examinations, what you're trying to do is you're trying to find that very, 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 very rare cancer that has started to grow in the tissue, say in the breast, but it hasn't yet spread through the venous system. It's still confined to the breast. Unfortunately, that's very rare to occur, to find that cancer still confined to the breast, if it's going to spread. There are cancers that are confined to the breast that never have an intention of spreading. They would have always remained confined to the breast. They're indolent cancers. And if you find those cancers, since they're already going to be in the breast, they're never going to move, you haven't saved anybody. And then you can find cancers in the breast that have already spread. You don't save anybody if you find those cancers. What you'll want to find is that intermediary, that one cancer that has the potential to spread, but hasn't quite yet. And your doctor's just gotten there in time and grabbed it and dragged it out of your body and saved you. That's what screening early detection is all about. Now, before we get into it, screening and early detection, I want you to realize what you're doing if you, when you agree to have a screening test done. When you agree to have a PSA or colonoscopy or a mammogram done, what you're agreeing to do is to risk your life and welfare today for the theoretic possibility that in 1, 2, 3 decades you'll be saved from cancer. Let me make it more specific. I'll give you the extreme example. Colonoscopy, which you're told to have, well, every 10 years at a cost of $2,000 to $3,000. The doctors, they come and ask you to have a colonoscopy, and what the doctor does is sedate you, gives you a light anesthesia, and then takes a 6-foot tube and sticks it up your butt, you know, through a tube that is bent. It has 2 sharp angles in it, the large intestine. So the doctor has to maneuver this tube up through this intestinal tract, looking for precancers called adenomas or polyps, or real cancers. And I realize doctors are very well trained in this, and accidents seldom happen, but they do happen. In the process of looking for polyps and biopsying polyps, 7% of people develop significant complications. That's 7%. That means bleeding, perforations, etc. 7%. The most serious complication of colonoscopy is perforation, where the tube goes through the wall of the colon, and then the contents of the colon spill into your abdominal cavity, and you go into peritonitis, and you go into the intensive care unit, and some people die. That's a complication. Occurs maybe in 1 in 2,000 people die. If you're that one person, that's a big deal. Maybe 1 in 1,000 get perforated. 7% have major complications from this procedure. So here's the scenario. Remember what I've said. You're hoping that by risking your life today, you'll prevent dying of colon cancer in 12 years. Here's the scenario. You're a 45-year-old healthy woman with 2 kids. And this, by the way, is something that I've seen. I'm not making this up. You're a 45-year-old female with 2 kids. You want to do the right thing. You go to the doctor. You have a colonoscopy done. The doctor perforates your colon. You get peritonitis and you die 24 hours later. You risk your life today for the theoretical possibility that you'd be saved from colon cancer in 1, 2, or 3 decades. And that's what you're doing. Now, you may want to do that. That may be just what you want to do, but you ought to think about it in those terms. This is not an innocuous procedure. It is also risky with things as simple as just getting your blood test, a PSA test for prostate cancer. If you say volunteer, because your doctor asked you to get a PSA test, you have a 10% chance of failing it as a man. You'll have a positive PSA. So once you flunk the PSA test, and one out of 10 of you will, then you have to have a biopsy, and the biopsy goes through your rectum, and they take 16 needles and they stick them in your prostate. And how often will you be found to have prostate cancer? Well, if you're over 50 years old, a male, at least half the time you'll be found to have prostate cancer. When you get to be up in your 70s and 80s, it's nearly 100% of the time they'll find prostate cancer. If you carefully look at a woman's breasts, say on the Western diet in her 40s, you'll find breast cancer in 40% of women. 40%. So what I'm trying to tell you is there's a lot of disease out there to be found. And you want to save lives, and you do occasionally, but you also hurt people too. You overdiagnose them. You diagnose them with a problem. Like I told you, half the men would have prostate cancer. Well, only 3% of men will ever die of prostate cancer. So there's a whole bunch of men who are now diagnosed with prostate cancer who've never known they had prostate cancer except from meddling doctors. All right. So that's what early detection is. It's the idea that you're going to find a disease before it spreads, and you're going to catch it in time to save you from dying of colon, breast, or prostate cancer. And by the way, just so you don't think I've missed this, colon, breast, and prostate cancer are caused by the Western diet. It's the food. So you really want to prevent cancer. You must give up the meat and the oil and the junk, and instead eat a starch-based diet with fruits and vegetables. So you understand what true prevention is. It's just like if you want to prevent lung cancer, you don't smoke cigarettes. I mean, you can do x-rays of the lungs as early detection, but you can understand the way you prevent a good share of lung cancer. You don't smoke cigarettes. The way you prevent colon cancer is you put the good things in the colon. All right, let me see if we can try something here, Gustavo. I was going to try and share with you a couple of slides to explain this to you in more detail. And let's see. This is not what I wanted to share, so excuse me a minute.
Okay, well, you find it. I want to mention one thing, Dr. McDougall. This weekend, the Advanced Study Weekend, was truly amazing. There were the highest caliber guests there you can possibly think. Just by gathering and listening to this information, just coming back, in the last 5 days, I've been able to lose 3 extra pounds. And it's just, these weekends, I want people to think about attending them. And I'm not paid to promote this. I'm just saying there's so much cutting edge research coming up, and this is a perfect way to get it all in one weekend. So, Dr. McDougall, let's see, you have it up.
Well, let's see what I can get up here, Gustavo. This is going to be a little sloppy for some of you who are real excited at webinars, but let me see if I can just show a couple of things here. I want to show you this this slide right here. This one from one of my slide presentations. This is you can read along with me. This is from the Annals of Internal Medicine in 2012. As a study, doctors went out and asked other doctors what they understood about mammography. What they understood about how mammography works. And so these researchers, they went and asked general doctors, internists, general practitioners, other type of general doctors, what was the value of mammograms? Mammograms where you take the steel jaws and you squeeze the breast and try and look for cancers in the breast to save a woman from breast cancer. So they went and asked a bunch of general doctors what they thought the value of screening mammograms were, or any screening tests. But let's focus on mammograms mostly. What it says, you can read along with me, is most primary care physicians mistakenly interpreted improved survival and increased detection with screening as evidence that screening saves lives. Okay, so improved survival, remember that word, improved survival. And the other thing is finding more cancers. That's what doctors think the value of mammograms are. And then go on to the next sentence. Few correctly recognize that only reduced mortality in randomized trial constitutes evidence of benefit of screening. This may be too much for you this early in the morning, but let me see if I can make some value of this. All right, there's a newsletter, and I want you all to write this down and afterwards go to this newsletter. And it's my my August 2014 newsletter. Here it is right here. Okay, can you see this newsletter? Can you see this, Gustavo?
Yes, we can see the newsletter. Sure.
Okay, August 2014. So if you want to refer to this, and I'm going to go through this fairly quickly. You want to maybe reread this, think about this. This is where all the information on today's subject is, screening. Early detection of cancer is a risky business, is what this says. Well, this is a whole list of cancer screening tests. We may take some time to go over this. Okay, so what I told you in that last slide was doctors believe improved survival time. Living longer is a benefit of, say, mammography. And do you see this, this little line here with some notches and a 0 and 5 up there? Do you see that, Gustavo?
I do.
Okay. All right. So let's take a look at this slide here. I look at the 0. That's the day you die. If you're not looking for cancer, move about 3 places to the left, and you see an arrow that says discovered here at about 2.5 years before you died. Say you weren't checking, you weren't doing early detection, and one day you're in the shower and you feel your tumor in your breast, and there it's discovered 3 years before, or 2.5 years before you died. You've only been alive for 3 years. Your survival time has been, 2.5, 3 years. Okay, say you get involved in a screening program, mammography, you're checking your breasts every day, you're having your doctor check your breasts. The day you die still is at 0. Look at the 0 on it would be your far right, I hope. The 0, that's the day you die. Now count back in years, 1, 2, 3, where we discovered the cancer when we weren't looking for it. 4, 5, 6, say 6.5 years before you die, say using mammography or other screening, you found the cancer instead of 3 years before you died, you found it 6 years before you died. Your survival time would have been doubled. You'd have lived twice as long knowing you had cancer. Your day of death would have still been the same day. You see, early detection finds tumors earlier, therefore your survival time is longer, but the day you die is the same. You live longer knowing you're sick. You live longer as a cancer patient. You live longer without your breast. You live longer not being able to get life insurance or health insurance. You just live longer knowing you have disease. That's what improved survival means from mammograms. I hope you can see that. The day you die is the same. If you're not looking for it, you will find it, a couple years before you die. The day you die is the same. If you diligently look for it, you may find it 5, 10, 15 years before you die, but you still die the same day. Okay, so that's false to believe, for doctors to believe that improved survival time is a benefit of mammography. It's not, it hurts patients. Okay, now the other thing is finding more tumors. People think is a benefit of mammography. It's finding more tumors. Well, look, this is the next little graph on that August 2014 newsletter. You see here at 0, or actually after 0, after the day you die, you have an autopsy. And the pathologist diligently looks through your body and finds all kinds of cancers. Well, okay, you've got a whole bunch of cancer in your body the day you die. If you don't go through early detection tests, likely you won't find those cancers because they'll be small or pseudocancers. They will be growing slowly. You won't find them if you don't look for them. But if you diligently look for cancer, say go back 6 years or so, and you go through all these screening tests, and the doctor looks for micro changes and biopsies this and biopsies that and biopsies this and biopsies that, and finds 2, 3, 4, 15 different cancers in you. Found a whole bunch of cancers in your body. Doctors believe using early detection to find a whole bunch of cancers in the body is good for the patient. Well, ladies and gentlemen, this is overdiagnosis. Most of these cancers would have never appeared they'd have never shown up in your lifetime. You'd have died of something first. So finding more cancers is not a benefit of screening. It just finds cancers that you shouldn't have known about. The only real benefit you can see from a screening program, you go down here to the next graph in that August 2014 newsletter, is you do a control trial. You take a group of people, you divide them into equal groups. One group you screen, that's a screen group. And the other group you don't screen, you don't do mammography or PSA or colonoscopies on them. And if the screening test really works, you should find maybe 10, 15, 20 years later that those in the screen group, there are more people alive. It saved lives. Whereas in the control group who didn't have the advantage of screening, there are more people who were dead. But that's not what you find. You see, when you do these type of mortality studies with mammography, PSA testing, and colonoscopy, there's virtually no difference. So yes, your survival time is greater because they found the cancer earlier. And yes, they find more cancers, but no, you don't live any longer. All right, so I told you that. Now I'm going to tell you something else, and I'm going to tell you why. Okay, this is why. This is, you kind of sit back and clear your head out a minute, because once I tell you this, you're never going to be the same. You see the screen up in front of you with a whole bunch of little circles, little balls. Those are cancer cells. And if you start at the very left side, you see one cancer cell, a little blue cancer cell. That's the first cancer cell. That could be in your breast or your colon or your prostate or your brain or your liver or so on. It's one cell that becomes cancerous, and it becomes cancerous as a result of being injured. And it's injured by chemicals from the environment, by radiation from the environment. There are many things that injure that cell. And a lot of those things are in the food you eat. So one cell, let's just say this cell is in the breast. One cell on the left. You see one cell, and right below it says cancer begins. That's the first cell that stops obeying the rules. And one of the rules is you have to divide only when necessary. Cancer cells divide at their own free will. Cells divide in life when you grow. When you grow from a baby to an adult, cells are allowed to divide. If you cut yourself badly, the cells approximating the wound are allowed to divide to heal. Otherwise, cells aren't allowed to divide. If they divided at their own free will, you'd become a misshapen lump in a matter of hours. Well, with cancer, the cells stop obeying this neighborly rule, and they start dividing at their own free will, and they divide very slowly. They divide about every 100 days on average for a solid tumor. Okay, so we begin with the first cell. It divides into two in 100 days. And then 3.5 months later, it becomes 4 cells. And 100 days later, it becomes 8 cells. You've had cancer in the breast for 1 year, and the number of cells in that tumor is about 8 to 12 cells. One breast contains 100 billion cells per breast. You've had cancer a year, you've got 8 cancer cells lurking in a breast that contains 100 billion cells. At this early stage of a year, what happens is some of these cells slip into the veins, and they go to other parts of the body, say the brain, the lungs, the liver, etc. And there they become metastases. They start growing they spread metastases. And they start growing and doubling about the same rate as the original cell. So go back to 1 year now, you've got 8 to 12 cells, you double it again, you've got 8, 16, 32. Now 2 years, you got 64 cells in a tumor of 100 billion cells, in a mass of 100 billion cells. So you've had cancer for 2 years. You've got less than 100 cells in that tumor mass. You can't find it by any means. You could even put a team of pathologists out there diligently looking at your breast. They're unlikely to find those 100 cells amongst 100 billion cells. The divisions continue, and finally at 6 years, you've got a tumor mass the size of a period on a paper. The size of a lead tip of a pencil. It's a millimeter in size. It's 1 million cells. It's been growing for 6 years. If it's truly cancer that will kill you, it has already spread. You can't find it at this stage. There's no instrument, no mammogram, no PSA test, no nothing that'll find it at this stage. All right, the divisions continue, and finally you get to the big red circle, and that represents 1 billion cells. That's a centimeter in size. On average, it's been growing for 10 years. Now, at a centimeter, it's big enough to raise the PSA level. It's big enough to feel with your fingers in your rectum or on your breast. Early detection is a misnomer. This is late detection. If the cancer is really a cancer, it's already spread to the rest of the body. If it's not a cancer, it's not likely to spread. You see, this is why mammograms and PSA tests and colonoscopies, they don't work well, because they're dealing with a disease that's already 2/3 of the way over. 2/3 of the illness is already passed. Anyway, you get hurt terrible as a result of this. And so let me just go one more thing, and then I'll give the table back to Gustavo, and you can ask questions. In this August 2014 label there, I put my recommendations for early detection tests. I think there are some that are worth your trouble. And these are based on U.S. Preventative Services Task Force recommendations and or the Cochrane collaboration. The two most respected scientific medical bodies in the world. And you'll see under support, either U, which is U.S. Preventative Services Task Force, or C, which is Cochrane collaboration. This is what these bodies of men and women, learned men and women, tell you to do in terms of screening, early detection. They say breast self-examination. No. Clinical examination where you go to the doctor and have the doctor check your breasts? No. Mammograms? Well, the U.S. Preventive Services Task Force says the harms are substantial and it should be discussed between the doctor and patient. And the doctor should tell the patient that there's a problem of overdiagnosis and that she may be harmed. She may have somewhere between a 5 and 50 chance of being told she has cancer. Out of 2,000 people, between 5 and 50 are told they have cancer, whereas they really didn't have cancer, overdiagnosis. And the U.S. Preventative Services Task Force says doctors must tell women this in the process of decision-making. Cochrane collaboration in 2012 came out and said, no mammograms. No, do not get mammograms done. That's what Cochrane said beginning in 2012. Thermography, no. Casual self-exam. So how do you find a cancer in your breast? Well, when you're taking a shower, if you feel a lump, bring it to the attention of the doctor. Don't get any more aggressive than that. You're wasting your time. You're putting yourself up for harm, not just wasting your time. Pelvic examination. Let's see. I gave a recommendation on pelvic exam. The U.S. Preventative Services Task Force last year came out and said that pelvic examinations should not be done. Let me just check something here. Other sources, yeah, that's what the O stands for. They came out and said pelvic exams should not be done. But the U.S. Preventative Services Task Force still recommends Pap smears. The problem is, how do you do a Pap smear without doing a pelvic exam? So they officially said, don't do pelvic exams on women routinely because you find more trouble than good. That's what the U.S. Preventative Services Task Force said. But you still have to do a Pap smear. What I say is that women should start getting Pap smears after the age of 21 if they're sexually active, and they should get them every, say, 5 years until they're, say, 50 or 60, and certainly should stop after they've had a hysterectomy. And those fit with general examinations. Cervical cancer is a venereal disease. It's spread by a virus. So HPV tests for that virus are recommended. Digital rectal examinations are recommended not to get them done. So says the U.S. Preventive Services Task Force. Every organization that I can think of that isn't tied directly to selling prostate business says don't get a PSA, including the American Urologic Association, which represents the business interests of oncologists and prostate doctors. Visual colonoscopy, no, I don't think you should get it done. Virtual colonoscopy, probably not. That's why they do it with an X-ray. I think a sigmoid exam. I suggest that as routine examination that men and women get a sigmoid exam, which is a 2-foot tube between age 55 and 60. There are a couple other options that you have available that are probably as good as an initial screening test, and that's to check your stool for blood. And there's a new DNA test called Cologuard. It's about $600 for the test. I think that's a reasonable way to screen once between 50 and 60. If you're found to be clean, no polyps, no cancers, then you should have no further testing. If you're found to have polyps or cancers, then it's a whole different regime, and nobody really knows exactly what to do, but you probably need more testing and treatments. Lung cancer, they say maybe in heavy smokers, CAT scans work. The U.S. Preventive Services Task Force says we should not be screening looking for skin cancers. Now, I think if you find something on your skin that it looks unusual, you should bring it to the attention of the doctor. But we shouldn't be massively trying to stamp out melanomas or other skin cancers. It causes more harm than good if it was put up as a screening program for a nation. Same thing with oral exams. If you go to the dentist and the hygienist or dentist doctor finds leukoplakia changes in your mouth, you should bring that to the attention of other doctors. But you shouldn't go out looking for people on the street and say, hey, come on in here, let me check your skin. Come on in here, let me check your mouth. You end up doing more harm than good. Well, that's my whole pitch on screening early detection. I think you should be very careful about becoming part of the medical business. These screening tests are the ultimate in disease mongering. Disease mongering is where you turn healthy people into patients. I think there are a few screening tests that are worth your while. Those would be pap smears for sexually active women at a certain period of time. I think one colon exam sounds reasonable. I think if you find something on your mucous membranes in your mouth or on your skin, you should bring it to the doctor's attention. Besides that, I think you should get on and live your life. Now, you can live it less dangerously if you take good care of yourself, like you don't smoke. If you eat the kind of food that I recommend, which is starches, vegetables, and fruits, it's the meats, the oils that promote cancer. We'll talk about that next week. But at least I hope I've given you pause when you consider allowing your body to be examined, looking for disease, taking you from a healthy person into a sick person. There's a lot of damage to be done. There's a little good. You know, sometimes people are helped. That's the problem, is some people are helped. But for every person you help, you hurt a tremendous number of other people. Gustavo, I think I probably took too much time. Are there some questions we can answer?
Well, Dr. McDougall, this is a very controversial issue, and I'm sure you know that.
It's only controversial, Gustavo, for those who put bread and butter on the table using these tests. Urologists, they hate this conversation.
Right.
People who run mammogram business, you know, your women's health center down the street, they hate this conversation. It's only controversial because it's very bad for the medical business. But everything I told you is true. You can go to that August 2014 newsletter. You can click the links. You can see whether the U.S. Preventive Services Task Force tells you not to do these things. Cochrane tells you not to do it. So the only controversy is in the education we've had that's created very willing customers to subject themselves to potentially dangerous tests. You should stop doing this without carefully thinking about what's going on.
Right, right. Well, here we have many questions. I'll just present them to you, and go. You let me know, and we can stop it. Right? Okay. So Janet says, "What should you do if you feel a lump in your breast and you are and you are less than 50 years old?"
Well, if you feel a lump in your breast, you know, women have lots of lumps in their breasts for many reasons. You have to make a judgment here yourself as a patient. You have to say to yourself, well, does this sound concerning? I mean, could it be current cancer? I told you, 40% of women in their 40s, if you look carefully enough, you'll find evidence of cancer. You know, so if you start looking, you're going to find. You want to bring to the attention a mass that is concerning. You know, if you have a lump in your breast that's been there for 20 years, hasn't changed, is smooth, it's not likely cancer. If you have something new grow that's hard and irregular, usually not painful, but hard and irregular, that could be a breast cancer. The reason to go see the doctor early, it's not going to change how long you live. Believe me, I just showed you that. It's not going to change the day you die. But say you go to the doctor with a small, say a tumor the size of a, I don't know, a marble. The doctor, when he or she provides definitive treatment, which should be removing the lump with clear margins, will be able to do a more cosmetically acceptable procedure on a small lump as opposed to a big lump. I mean, the lumps get so big, sometimes the only way you can take them off is to take the whole breast off. So what I've been recommending for almost 40 years now is a woman who finds a lump, is suspicious enough to bring it to the doctor's attention. Because believe me, if you get in the medical business, ladies, you know, the doctor's worried now. The doctor's worried that he or she is going to get sued. The most common reason to get sued for a physician is failure to diagnose breast cancer. So the doctor's going to move forward. So you have to make some discretion here by yourself as to how willing you are to get into the business. So you take the lump. So you take a breast, have your breast examined by the doctor. The doctor says it's suspicious. You need to take the lump out. The reason you need to take the lump out is because it keeps getting bigger and bigger and bigger and bigger. I've seen about 6 cases of untreated breast cancer in my career. It's not a pretty thing. It looks like a piece of hamburger stuck to somebody's chest. So you want to get local control. So you do want that tumor taken care of. If it has not spread, as I showed you before, it's likely not going to spread. If it has the potential to spread, it's likely spread by the time you found it. It's a 10-year-old disease. There's no rush. You need to think about this. You need to be making some decisions. So generally, I just get a lumpectomy with clear margins done on my patients.
Right. Okay. Very good. Deborah says, I have had colonoscopy, which detected and removed precancer polyps. Why would someone not want to do this?
Well, the reason you would want to not do it is because sometimes people get hurt with these procedures. I suggest a sigmoid exam, which is a short tube about 2 feet long, and as opposed to a 6-foot tube, because there are virtually no complications with sigmoid. They just don't do them anymore. That's not the bread and butter of the gastroenterology business. They make their big bucks by passing the big tube. So do the hospitals where they pass it, or the exam facilities where they pass it. You can get as good a survival. You know, we're talking about screening 330 million people in the United States. That's sometime in their life. You can get as good a survival with a sigmoid exam as you can with a colon exam. Why take a colonoscopy exam? Why take the risk of the colonoscopy exam if you can get the same results with the short tube with less cost and less risk? And I'll tell you also, you can get as good as survival benefits just by checking the stool for blood around that age. And then if there's blood in the stool, you go on with further procedures. Or this new Cologuard, this is a DNA test that finds DNA in polyps, a special kind of DNA in polyps and precancerous lesions. This Cologuard test, which just came out this year, is a very effective screening test, so far it looks to be, which will give you as good a chance of delaying death as will be a colonoscopy. Yeah, I mean, you can do a colonoscopy. I mean, colonoscopies miss 20 to 40% of the polyps. You want to be really good, why don't you just go to the doctor, submit yourself to general anesthesia, go to sleep, have a couple of general surgeons come in, slice your belly open, pull your colon out, cut a big long slit in it, and look real carefully with a magnifying glass all through your colon to make sure you don't have any polyps. Well, you say, that's ridiculous. Well, believe me, if it didn't sound ridiculous, there'd be people doing it to make a buck and to keep you from having cancer.
Right.
I think as far as they go now with the large tube, the colonoscopy is pretty radical, especially when you can get same results with sigmoid exam and or fecal blood and or Cologuard. I mean, why do more than is necessary? And you can say to me, yes, and it is true. But doctor, you'll miss somebody that would have benefited from that colonoscopy. You're right. I'll have missed somebody, and somebody will die as a result of that recommendation. But I can also say to you, I saved somebody from getting killed from perforation due to a colonoscopy. I did that too. Or dying from general anesthesia. I did that too as a recommending doctor. You know, you got to take into consideration there are benefits and risks to all these tests. And you need to read them over. I think my August 2014 newsletter is extremely fair. Read them over, decide where you're going to take your risk at. As they say, you could drive down the highway wearing your seatbelt, and if you get hit by a truck, you could be trapped in the car and burned to death because you had your seatbelt on. And if you wouldn't have had your seatbelt on, when that truck hit you, it would have thrown you out the window and you'd have been saved. So it's stupid to wear safety belts. You know, all kinds of things happen in life. You try and guess based on what's happened to other people who got mammograms or PSA tests or digital rectal examinations or colonoscopies. You know, you look at how many people got hurt, and you look at how many people got benefited. And you look at how much it costs, how much money spent, and how much diversion of healthcare costs we have done, that we could maybe use this money to teach kids not to eat meat instead to eat potatoes. I mean, you got to consider everything, and that's what the U.S. Preventive Services Task Force does. That's what the Cochrane Collaboration does. My recommendations are solidly based on these prestigious organizations and their thorough reviews of the science, trying to figure out how the average citizen would benefit or be harmed by screening. And you can read it yourself, and then you decide, well, you know, I don't believe that. I think if my doctor looks in my colon, he or she's going to find a cancer that's going to save my life. Well, I'll go have a colonoscopy. But you shouldn't go have these tests done thinking that they are without any adverse consequences, because that's not true. Once you submit your body or body parts to the medical business, you are now in the business.
Right. And that's when I think it becomes personal, Dr. McDougall, because each person has to weigh the dangers and the benefits, and that's what you're saying. And we, regular people, I'm not a medical doctor, I'm like everybody else here in this conference, we get a lot of pressure from our doctors to get these exams. So what do you say to that when our doctors are pressing us to get the exam? What should we answer?
It's really hard, Gustavo, because you're dealing with men and women who have, well, they start out as the cream of the crop. These are the smartest people in the country because they get accepted to medical school. So they have this great potential to do great good or great harm. And we have an attitude in this country that doctors are next to God and their only interest is in our welfare. You need to get over that. That's not true. These are business people. By and large, as I showed you just about half an hour ago, your doctors have no idea what these tests do. And I just showed you, they believe that their benefits are improving survival time, which means you live longer knowing you have cancer. That's not a benefit. They believe that the mammograms and other tests are beneficial because they find more cancers. Well, these cancers, most of them would have never harmed you. They overdiagnose it. Now you live as a cancer victim. So even your doctors don't know. And they believe, excuse me. Believe me, they don't know. I deal with doctors all the time. They just are plain ignorant. But to me, that's not right. Your doctor went to school for at least 7 years to become an expert in human beings. And there's no excuse for a doctor not knowing the facts that I just shared with you. The U.S. Preventative Services Task Force knows those facts. The Cochrane Collaboration knows those facts. The device industries and I mean, all kinds of people know these facts. And every doctor should know these facts, and you should be presented the information just as I presented it to you just now. You go in and you talk about, and that's what the U.S. Preventative Services Task Force says. Cochrane says don't get a mammogram. The U.S. Preventative Services Task Force says that if you're considering a mammogram, the doctor needs to sit down with you and say, well, ma'am, you know, we might find a cancer, and we might find it early enough to remove it and save your life. We're going to deform your breast. We're going to maybe even amputate your breast. And in my practice, in addition, we'll take the lymph nodes out of your arm, and you'll likely have a swollen arm the rest of your life. And in my practice, if I find a cancer, I'm going to radiate it. And since your cancer is on the left side, I'm going to at least double your risk of dying of heart disease from the radiation. And even if I do mastectomy and radiation, there's still a 10% chance that the tumor is going to come back to your chest. And also you need to know, based on over 60 years of research, of study, that these treatments make little or no difference in your survival. And your doctor should be talking to you this way. It makes little or no difference in whether you live or not. And ma'am, you need to know that there's somewhere, if there's somewhere between, say I check 2,000 women. Let me say the facts this way. Ma'am, if I do 2,000 mammograms, I may save one life. I might save one life, ma'am, if I do 2,000 mammograms. But in the process, I will diagnose at least 5 and as many as 50 women with breast cancer that would have never known they had breast cancer. They would have never shown up. But those 50 women, let's just say it's 50, I'm going to give them the same treatments. I'm going to give them the lumpectomy, the radiation, the mastectomy, the chemotherapy. They're getting the same treatment as the one who really needed it. And you know, you never know who you were. You never know whether you were the one that needed it or didn't need it. You can't tell. All you can tell is by statistics that 1 benefited and 5 to 50 were diagnosed with a tumor that never showed up. And in the process, let me tell you, if you get mammograms and you do it on a regular schedule, which is, say, a mammogram every 2 years for a period of 10 years, if you're dutiful and you do that, then you have a 50% chance. Half of the women who go through this recommended procedure will end up being diagnosed with problems that require more testing and treatment. You are in the business. Right.
Dr. McDougall, yes, this conversation is really fascinating and very enlightening. There's a person here that her name is Kersey, and she says, is it true important to keep your body pH at 7 to help keep disease and cancer rate down?
Well, that's a good question, and probably a little lighter than the conversation we've been on. The pH 7 is neutral. Below 7 is acidic. Above 7 is alkaline. The human body's pH is about 7.4, so we're slightly alkaline. And what you don't want to do is you don't want to eat an acid diet. An acid diet is a diet of chickens and fishes and cows and pigs and lobsters, and that's acid. So you don't want to eat an acid diet. You want to eat an alkaline diet, which is fruits and vegetables. Grains and beans are slightly acidic, not much. The amount of acid the body can easily handle. Cheese has 10 times more acid, 10 times more acid than does peas or wheat. So, you know, if you want to stay away from, eating an acid diet will lead to heart disease, cancer, hemorrhoids, all kinds of things, because what you're identifying is animal foods. So keeping the body alkaline, you do it by eating fruits and vegetables, potatoes, spinach, tomatoes. That's how you keep the body alkaline. And yes, that will prevent cancer and constipation and heart disease. And so you're getting to an important question or an important answer by a little bit of a different question.
Right. Okay. Jeff says, does that mean treatment after early detection is not any more effective than treatment without early detection?
Let me see. If you treat with early detection, you may find the tumor at a smaller size, so it may be easier to treat. So you can say there are a couple of advantages to early detection. You're saying there's no advantage. So you do save some lives. You can find the tumor smaller, and if necessary, you can get the person scared enough once they have cancer to give up the beefsteaks and instead start eating the pasta. So people tell me, well, if I only knew I had breast cancer, I'd have changed my diet. If I only known I had prostate cancer, I'd have eaten the bean burritos you recommended. Well, ladies and gentlemen, you're sick enough. You don't have to find more things wrong with you to change your diet. So yeah, early detection is a misnomer. It's late detection. The cattle are already out of the barn before the door is closed. It's a 10-year-old disease on average. Everybody should know this. So you make decisions.
How many more questions do you want to answer? One more or two more? Or
sure, let's answer it, because I took a lot of time, and maybe we should, Gustavo, I think with these seminars, we should probably get more questions in rather than me just sitting and lecturing.
Right.
But I just get carried away. Sorry.
That's okay. So how do you explain cancer in young children and lung cancer in folks who never smoke?
Well, my guess is that young kids get cancer either from chemicals that mom ate, when mom was pregnant. There are various chemicals in her diet. Of course, most of them come from the animal foods. Viruses sometimes will infect the fetus, the young baby, and give them cancers. The nice thing about cancers of children is we do have some pretty good treatments. We also have some pretty good treatments for leukemias and lymphomas. Let's see. That's about it. We have terrible treatments for brain cancer, lung cancer, colon cancer, breast cancer, prostate cancer. Our treatments are horrible, horrible, horrible. No bragging rights allowed. As far as lung cancer and non-smokers, these are generally adenocarcinomas, whereas smoking cancers are squamous type carcinoma. There are glands, mucus glands, just like when you cough, mucus comes up. There are mucus glands distributed throughout the lungs, and these mucus glands are also present in the cervix of a woman, in the colon of a person. So you have mucus glands in the body, and they get cancers from chemicals, environmental chemicals that are produced by industry. And they also may be under the influence of viruses. I mean, it's a different kind of cancer. So non-smoker cancers are generally adenocarcinomas. And they're not like smoker cancers. Yeah. That's from the food. Hey, look, it's from the food. I'm a broken record. It's the darn food. You eat 1 to 5 pounds of your food a day, and the food is full of environmental chemicals, and it's in most people's diets terribly imbalanced. It's balanced for a cat or a lion, but it's not balanced for a human being, and you just don't stand a chance. The body falls apart.
Right. Dr. McDougall, just quickly, and this is probably the last question.
Okay.
Have you ever seen anyone stop the cancer or reverse the cancer?
Yes, I have. I've seen, I've been at this for 40 years, and we'll be talking about this next webinar, which will be a discussion that includes my February 2015 newsletter. Not only have I seen cancers that have completely gone away even when they're in the entire body, is the person that's in the brain, the bones. I've seen it go away. It's been reported in the scientific literature. I provide the references for that, so you can see that other doctors have seen cancer completely go away. I believe, I'll just tell you my general belief, and this will be a good transition for next week, is I believe that by changing the diet, you can slow the doubling time. So we started this conversation. I showed you how cancer doubles on average every 100 days. Well, some cancers double every 30 days. That's not good. And some cancers, they double every, every 800 days. That's good. If your cancer doubles, say, every 300 days, well, anyway, if it doubles slowly, then you die of breast cancer at 175 years old. I believe by changing your diet, your immune system works better, kills more of that cancer. The body's always trying to kill cancer. The body never stops trying to kill cancer. Next week, I'll show you evidence where women with breast cancer, in a period of 6 years, without even changing their diet, documented by the best researchers in the world, published in the best medical journals in the world, without even changing diet, without doing anything, the body cured itself 22% of the time of invasive breast cancer. That's without even being healthy. 22% of the time. It ate up the cancers and they went away.
Right.
Regression of breast cancer. So I believe, in my 40 years of experience and all the patients and research I've done, is that people with cancer, if they eat well, like I recommend, this is what I consider eat well, that you can slow the progression of the cancer, stop the progression of the cancer, and in some cases get what we call spontaneous regression. It goes away completely. And I have some reported cases of that. Every doctor does. I mean, you take a look at any general surgeon out there and you ask them, have you ever had a case of a patient with cancer all over the body that went away? And they'll say, oh, yeah, I had a couple of those. Well, my last comment, and here's where we'll stop, is I think the chances of spontaneous regression of the body curing itself of this disease, and it's always trying to cure itself. It never stops trying to cure itself. I think the chances of the body winning are better for a healthy person than a sick person. I think a person in good health has a better chance of winning this battle. And I know why most people aren't in good health. It's the food. And so if you fix the food, I believe, and not only do I believe, so does the American Cancer Society believe so, which we'll talk about next week. And so do the experts at Up to Date, which is a big medical resource. They believe so too. The general medical business that is well informed now believes that a person who gets cancer needs to eat a healthy diet, not only for the quality, but for the quantity of their life. And that's what we'll talk about next week. How's that sound, Gustavo?
That sounds great. And next week, just a reminder, the webinar is on Saturday morning and not Friday morning. And these webinars are recorded, as many of you are asking right now. So in about an hour, you should receive a link that you can watch it. It doesn't have an expiration. Thank you, Dr. McDougall.
It was a pleasure. Thank you, Gustavo. And folks, spread the good word. We've got a world to change.
Very good. Bye-bye. Thank you.